2021. We really, really do appreciate you doing this, Dr. Oyeleke. I just want to say a big thank you on behalf of MDoc team, the Project Aisha team, and the Project Hash team. I will just go ahead and introduce Dr. Oyeleke. So she's a consultant physician, gastroenterologist, hepatologist at the Lagos State Teaching Hospital, Nigeria. In 1995, medical graduate of the prestigious University of Ilorin. She was awarded an internal medicine fellowship of the National Postgraduate Medical College in Nigeria in 2029. Prior to joining Lagos State Teaching Hospital in 2015, she worked as a consultant physician, gastroenterologist at the General Hospital, Broad Street, Lagos, for 5 years. She has attended various local and international trainings, courses, and conferences, and has published a peer-reviewed journals, has been published in peer-reviewed journals, giving talks and presentations on the liver and gastrointestinal disorders at many local and international meetings. Dr. Oyeleke is an examiner in the National Postgraduate Medical College of Nigeria. She is also a fellow of the American College of Gastroenterology. She's a member of the Society for Gastroenterology and Hepatology in Nigeria, a European association. She's also a member of a European Association for the Study of Liver, member of the American College of Physicians, also member of the Society for Gastrointestinal Endoscopy and the American Academy of Hospice and Palliative Medicine. She is actively involved in medical education at work and in her community. She is a coordinator of the World Gastroenterology Organization Lagos Training Center, a co-director of the Lagos Viral Hepatitis ECHO, a branch of the Sub-Saharan Project ECHO. So she's not new to this at all. And, she's a member of the African Association of Future Gastroenterologists and also a mentor. She's also a loving mother, loving wife, and enjoys to spend quality time with her extended family. It is safe to say that Dr. Oyeleke is well-rounded. She is overqualified to deliver this session. We give it up to Dr. Oyeleke as she comes on board to take the stage and start her presentation. Thank you again so much for taking all the time to do this for us, Dr. Oyeleke.
Good. Yeah, so good afternoon or good morning, everyone, from wherever you are. And thank you so much, Chair Goze, for the beautiful introduction. I'd like to thank you for inviting me for this talk. So special thanks to MDoc and the team, Project Hash and Project Aisha. So we'll just go straight right to the topic. I think we've spent a lot of time before this. So the topic for today is hepatitis B virus. So next slide, please. Okay, so the topic for today is hepatitis B in pregnancy. Is the bark worse than the bite? So next slide. So I'll be discussing that under the outline. Next slide. So this is the outline through which I'll have the discussion, please. So if you have questions, comments, you can just keep it in the chat and we'll take everything afterwards. Next slide, please. So I thought to start with something a little funny. So when someone's bark is worse than the bite, it means someone's actions are not as bad as their threat. So really, the actions of hepatitis B in pregnancy worse than what we really shout about? We'll get to know later on. So next slide. So first we start to introduce hepatitis B. And I'm glad Chair Gozi mentioned earlier that this is the week for hepatitis awareness. World Hepatitis Day is on Friday, 28th July. So it's the day set aside to increase awareness of viral hepatitis generally. So I'm starting with hepatitis B, which is one of the hepatitis viruses. We know we have about 5 of them: hepatitis A, hepatitis B, hepatitis C, hepatitis D, hepatitis E. So we're starting and we're focusing majorly on hepatitis B. And the reason why we're doing that is because it's a special virus to us. It's a double-stranded DNA virus, and it causes liver inflammation, predominantly liver inflammation that can result into chronic inflammation, meaning inflammation that has lasted more than 6 months and can rapidly or gradually or slowly cause damage to the liver over time. Next slide, please. So before we go straight to what inflammation of the liver is and how it affects pregnancy and all that, it's good to understand the liver itself. Our liver is the largest solid organ in the body and is situated right on the right upper side of the body, right underneath the ribs. It weighs about 3 pounds and it does the following functions. It helps to remove waste and harmful chemicals from your body. It helps to fight infection. It makes substances that help to digest food available. It stores nutrients, vitamins, and hormones, and it helps to store sugar as energy. So you can see that the liver is really a very important and very vital organ of the body, aside being the largest solid organ. Next slide. And in terms of epidemiology, we know that hepatitis is a global disease, kind of hepatitis B, for example. And globally, we see that some countries have more impact, or hepatitis B impacts more countries than the others. For example, in Africa and sub-Saharan Africa, we can see that we have a higher prevalence, so to say, or burden of hepatitis B. The current estimates in Africa, in sub-Saharan Africa, is about 60 million, and same with other countries in sub-Saharan Africa and in some other countries in Asia. In some developed countries, it's not as common, but it's still a challenge to the resource-limited countries, sub-Saharan Africa and some parts of Asia. Next slide. So what's all the noise and the fuss about hepatitis? How do I get, that's how people, really, how do I get hepatitis B, for example? And when we teach medical students, we say there's vertical transmission and there's horizontal transmission. The vertical transmission, which is the focus of our discussion today, is the transmission from mother to child. We know that a woman that has hepatitis B can pass the hepatitis to the infant, to the baby she's delivering, particularly during delivery. So that is a very important mode of transmission of hepatitis B. We also know that hepatitis B can be transmitted horizontally from one person to the other. In sub-Saharan Africa, in some parts of Asia, child-to-child transmission has been well documented. So you find a lot of people being exposed to hepatitis B in early childhood. Also, we know that it can be transmitted through contaminated needles, through sexual transmission, through transmission through blood transfusion, or transmission of blood products, or sometimes through injection from quacks, through unsterilized manicure, pedicure, all the things that requires contact of blood through shafts can transmit hepatitis B. But we note is that perinatal transmission, that's the vertical ones, are the ones that are of most important, because infection at this time to the infant results into a high level of chronicity. The child is not able to wipe out the hepatitis B from the blood, and the hepatitis B stays back and become a chronic infection in the child, which can continue to cause damage. So approximately 40% of infants born to hepatitis B infected mothers would develop chronic hepatitis B. And some data have suggested that 90% of children infected at birth would develop chronic infection. And an estimated 25% of these individuals will die prematurely. So this is a very important aspect of the transmission that we must deal with. Continued prevention of perinatal transmission is an essential component of the ongoing effort to decrease the worldwide impact of hepatitis B. And we know that perinatal HBV transmission can be prevented by identifying infected mothers and treating them or providing prophylaxis to them in pregnancy and even to the child when the child is born. Next slide, please. So the question is, how do I identify if I have hepatitis B? And what are the risks, or how do I identify who is at risk? So to identify hepatitis B sometimes could be challenging because most times people do not experience any symptoms at all. Sometimes when the symptoms will occur, it could just be abdominal pain, which is usually on the right upper side where the liver is located. Sometimes there may be vomiting. Sometimes the whitish part of the eyes will turn yellow, which we call jaundice, or even the skin becomes yellowish. And the fair skin people, for us that are dark skin, that will not show. The urine becomes dark yellow. There may be extreme fatigue and the person may have some nausea. But it's important to note that majority would not even experience the symptoms, or they will just assume that the symptoms are similar to symptoms of malaria, so to say. Hepatitis B is spread by exposure to blood or body fluid, by household contact of infected persons, like we said earlier, using of sharps, razor, even toothbrushes, and by transfusion or organ transplantation, or even donation of organs or body fluid like semen and all that. Injection drug use is a common mode of transmission through infected needles. And we know that it could be sexually transmitted and transmission from mother to child. Next slide, please. So while we talk about how hepatitis B is being transmitted, it's also good to understand how it is not transmitted. I repeat, we should know how it is not transmitted because, I mean, even as last week, somebody still told me that, oh, could I have been infected through infected water that I drank? Hepatitis B is not transmitted through sharing of food or water. Hepatitis B is not transmitted through sneezing. It is not transmitted through coughing or through breastfeeding or through sharing regular eating utensils like the spoon or fork, or through kissing or holding hands. There must be a break in the mucosa or a break in the skin before transmission occurs. For breastfeeding, however, we usually advise that the mother should get the baby immunized before the child starts to breastfeed. Next slide, please. So we've talked about the symptoms, that it's majorly without symptoms in most cases. But if the symptoms will appear, it could be fever, like I said, or jaundice, yellowish discoloration of the eyes, malaise, tiredness, there may be body pain, there could be passage of dark colored urine and all that. Unfortunately, there are times when people come to us even already presenting with complications, and the complications we worry about are ascites. Ascites is when there's fluid accumulation in the tummy and the tummy becomes really distended. Hepatomegaly means liver becomes enlarged, or even shrunken liver. The liver becomes shrunken. When liver shrinks, it is when there is advanced scarring in the liver, which we call liver cirrhosis. Scarring that becomes so much in the liver and the liver starts to shrink. Or if there are other complications, we call portal hypertension, the spleen becomes enlarged, then the patient can start to vomit blood, or the most dreaded of the complication, which is liver cancer. So unfortunately, we still see people presenting with these complications for the first time. But at that time, it's far too late for any curative treatment, unfortunately. So that's why we're preaching prevention and we're discussing all this. Next slide, please. So how do we identify hepatitis B, and what are the investigations to do? Since we said it doesn't really have, for most people, there are no symptoms. The first investigation will be we call it the hepatitis B surface antigen, HBsAg. For those that are not medical people or they are not familiar with this, these are tests that you can do in the laboratories or in the hospitals. If you discuss with your doctor, they'll be able to contact you to where you'll be able to run the test. The surface antigen is the regular hepatitis B screening that can be done. It's pretty available in most laboratory and it is affordable. It's World Hepatitis Awareness Week, like I said. So in most of the centers now, they are even doing free screening for hepatitis. So it's a good time for us to know whether we have hepatitis B or not. There are other investigations we do. We call it a profile of the hepatitis B to know for how long you've had it. Is it an aggressive? Then we do the hepatitis B viral load DNA, which is the one that counts how much of the viral. But it's good to state that we know this is available not in all areas in the country, and not in most places. And where it's available is also not free. Viral load costs an average of 20 to 50%. In some private places, even much more than 50,000. So it's important that we go to a place where we can get it at a much subsidized rate. Liver enzymes and liver function tests are done just to check as a hepatitis even affected the liver. Then we check the kidney function. If we're going to start someone on medication, we have to be sure that the kidneys are good. The full blood counts will also give us more information, the blood, the level of blood, if the platelets are adequate. Platelets are also produced by the liver. When liver is severely impaired, then the platelet production drops as well. Then we do a scan, abdominal ultrasound. We want to see the appearance of the liver. Is the liver still normal in size? Has it become enlarged? Like I mentioned, be part of the symptoms of the signs, or has it become shrunken? Are there other things in the liver? So these are basic investigations we do for patients with hepatitis B. Next slide, please. So concerning patients that are pregnant, what are the recommendations by the CDC, is the Center for Disease Control? Universal screening of pregnant women.
They can't give that boy paracetamol. I never see say I don't give him paracetamol.
Can you please mute? Thank you.
Yes, please. Yeah.
All right. So yeah, okay, so I was discussing the recommendation by CDC, the universal screening of pregnant women for hepatitis B surface antigen during each pregnancy. It's important to screen for each pregnancy, because you hear some mother will say, oh, I screened 2 years ago when I was pregnant for my first child. You have to screen again during this pregnancy. Every pregnancy, you must be screened. Screening all hepatitis B surface antigen pregnant women for hepatitis B DNA to guide the use of maternal antiviral therapy during pregnancy. And the American Association for the Study of Liver suggests maternal antiviral therapy when the viral load is greater than 200,000 international units per mil. We're going to discuss a little bit more on this later on. Case management of hepatitis B surface antigen positive mothers and their infants, and provision of immunoprophylaxis for infants. And what do we call immunoprophylaxis for infants? It is a special injection. It's called the hepatitis B immunoglobulin, which is given within 12 hours. That's the best. For some, we can extend to 24 hours after the child is born. This immunoglobulin B to the infant born to an infected mother, hepatitis B infected mother, is given along with the hepatitis B vaccine, the birth dose of the hepatitis B vaccine. So it's important that we note this. There are some challenges with this which we should note because of the cost and because of availability. So there's a slight modification to this recommendation, which we'll discuss on the next slide. Routine vaccination of all infants with hepatitis B vaccine series with the first dose administered within 24 hours. So usually we advise that even for all children, they must get that birth dose, or which I think in vaccination time, they call it the 0 dose. So it's important to emphasize that all children should get the vaccine at birth. It's for children that are born to hepatitis B positive mothers. It's compulsory for them as much as possible. I know there are challenges at times when a child is born on a weekend, for example, they'll say, oh, vaccination day is on Tuesday and all that. So we're trying to emphasize to make sure that this is done now at a, right? Okay, so next slide, please. Next slide, please. Yeah, so hepatitis B, the World Health Organization, WHO, recommends that pregnant women testing for hepatitis B infection with a DNA of greater than 200,000 must receive tenofovir prophylaxis from the 28th week of pregnancy until birth to prevent mother-to-child transmission. So for the World Health Organization, the recommendation is 200,000 international units and above if the DNA is up to that. But we know that we have challenges with this because I just mentioned that the DNA is not readily available. Sometimes when it's available, it may not be affordable. So there is a new recommendation for resource poor country. Next slide, please. So for patients in the setting in which antenatal HBV DNA is not available, the hepatitis B envelope antigen, which we call the HBeAg testing, can be used as an alternative to HBV DNA testing to determine the eligibility for tenofovir prophylaxis. Tenofovir is the medication we use for hepatitis B. So the prophylaxis is given to mothers from 28 weeks if they have a high DNA of greater than 200,000 international units per mil, or if you cannot do the DNA, we do the hepatitis B envelope antigen. That is available and it is fairly readily affordable, about 3,000 or 4,000 in most places. So that is important. If that comes and is positive, then we should make sure that we start the mother on tenofovir, 300 milligram, if there are no contraindications to that. Now, for the baby that is born at this time, the baby receives post-exposure prophylaxis. And I'd mentioned the hepatitis B immunoglobulin into the deltoid within 12 hours of birth, along with the first dose or the birth dose of HPV vaccine. Then the baby will subsequently go on to complete the vaccination dose at 6 weeks, 10 weeks, and 14 weeks. Breastfeeding is commenced once the baby receives the first dose, that's the birth dose of the HPV vaccine. And the mother continue HPV monitoring and will treat the mother as appropriate. We must note that this is what is best, but we should know realistically, because the cost of hepatitis B immunoglobulin is about 55 to 60,000. And we know not every mother is able to afford that. So where this is not affordable or where it is not available, then the child must receive the birth dose of hepatitis B vaccine. I repeat, if it is not affordable or it is not available, we can still just give the birth dose of the vaccine, but the best is to get the hepatitis B immunoglobulin. Next slide, please. So I'm putting up this slide because I feel it's important. Sharing food and water will not transmit hepatitis B. Sneezing, coughing, breastfeeding, sharing utensil, kissing, holding hands, and sweat will not give hepatitis B, please. Thank you. So next slide. Next slide. Okay, so similar to what we've discussed, so this is just like a recap. You can get hepatitis B by being born to a mother with hepatitis. You can get it by coming in contact with infected blood or from an injury or scratch or bite, anything that causes a breakage in the skin. You can get it by having sex with an infected person or through tattooing, body piercing with unsanitized tools and all. You cannot get it by drinking water again, or touching, or kissing, or sharing food or cooking utensils. Next slide, please. So the theme for the World Hepatitis Day this year is "We are not waiting." Oh, I am not waiting. We're not waiting to get tested, and we shouldn't wait. We're not waiting to get treatments, and we're not waiting to educate ourselves and each other about hepatitis. Get tested for hepatitis. It could save your life or the life of your family members. Next slide, please. Next slide. So in conclusion, during the first pregnancy or subsequent pregnancies, check hepatitis B surface antigen or anti-HBC. If the person is negative, you vaccinate, and make sure that you vaccinate the infant as well. If the person is positive for hepatitis B surface antigen, you do the DNA and you do the other tests that we talked about. If the hepatitis B DNA is greater than 200,000 IU, then you consider treatment at 28 weeks. But if it is less, you just do not give any treatment. You continue to monitor the mother, but the child will still get immunoglobulin. So the eligibility for the commencement of tenofovir prophylaxis for mothers is the 200,000 international units. If they are up to that or more, then you start treatment even in pregnancy from 28 weeks. But if they are not up to that, if it's not up to that, or the HB envelope antigen is negative, then you don't need to start treatment for the mother at that time. You would start to treat the child at delivery, or you just give the prophylaxis to the child at delivery. Next slide, please. Yeah, so these are my references, and I think I'd like again to thank the organizers for inviting me for this talk. And just to remind everyone, if you're pregnant, or if you have people that are pregnant, or your patients are pregnant, advise them to get tested for hepatitis B early, as it can save the lives of the mother and the child. Thank you all so much. And the floor is now open to questions and comments. Thank you.
Thank you so much, Dr. Oyeleke. My name is Aima Waboy, and I'll be taking the next half of this, anchoring the next half of this echo. Thank you, Dr. Oyeleke. That was a very engaging session. So do we want to have some reactions first? But I think that we'll go straight on to the case presentations. After that, we'll take the reactions to both presentations, and then take our questions immediately after. Yes, so please, can we have the case presentation? Thank you, Matron Malomo Adenike, over to you. Thank you. Matron Malomo, are you on? Are you able to speak? Matron Adenike, please.
Good afternoon, everyone.
Afternoon, welcome. Thank you.
All protocols duly observed. So, this case presentation, the biodata of the patient, name, not exact names, please. Name, Mrs. KPE, age 30 years, married, from the Yoruba tribe, a Christian, and into business. She's a secondary school, level of education is secondary school certificate. Parity, she's gravida 2, para 0+1. One means abortion at 8 weeks, 4 days. The last menstrual period with us was 10/12/2021, and the estimated or expected date of delivery was 17/9, that is September 2022. the gestational age was 30 to 32 weeks, as done by ultrasound scan. Then the presenting complaint, she did not have any complaints at that time. Next slide, please. Anyway.
Sorry, please just give it a few minutes.
The present.
Yes, okay.
Okay.
Yeah. Okay, can you see the slides now?
No, not yet. Okay, thank you. It's on now. Thanks.
Okay.
So, new complaints at the time she came, she just commented that she did some tests sometimes and was instructed to take some injection for baby after birth because she was coming in from another area entirely. So, at the time,
Mechoma, I think there's a challenge with your network. We can't hear you.
Present complaint was fatigue, tiredness, the mild yellowness of the eyes, right ovarian cyst, and hepatogenous dermatitis with vaginitis. No surgical history, obstetric and gynecology history, just gravida 2 para0 plus 1, missed abortion at 8 weeks, 4 days, nil allergy, then family and social history. She's a third child in a family of 4 children. Mother and father are still alive. She changed her name 2 years ago due to divorce from her husband of 5 years. Then on abdominal findings, abdomen gravid, movement with respiration, soft, and the height was 28 weeks. Then fetal heart rate was 140 beats per minute. On general examination, she was not pale, just mildly icteric, afebrile, not dehydrated, not cyanosed, and pedal edema. On systemic examination, she was just essentially normal. So diagnosis of hepatitis B, surface antigen was positive, and then hepatitis in pregnancy was diagnosed for her. Management on I advice on antenatal clinic, counseling done, and reassurance. Encouraged to get hepatitis B immunoglobulin and vaccine, for the baby after, that should have been after birth. So we advised her to get ready the hepatitis B immunoglobulin, but because of the, the financial situation of the family, she couldn't get that. But at birth, anyway, as management continues, she delivered at 38 weeks via spontaneous birth delivery. No complaints, no complications. Then she attended the postnatal clinic at 1 week and 4 weeks. And 4 weeks, then she moved on again because of a geographical barrier. She had to go to another, she did not come to us thereafter. But however, the baby was given hepatitis B with us at at birth. The 0-1 was given at birth. But the 6 weeks after, she did not come because she has relocated again from this environment. Thank you. And that's our case presentation. Thank you everyone for listening.
Thank you so much, Matron. Thank you so much. And thank you, Dr. Ganiyat Oyeleke, again for such a lucid, interesting, and then simplified presentation. We enjoyed every bit of it, and it was great learning for us. Thank you, ma'am.